Okay, so this is our lecture on breast MRI. The lecture after this is going to be another breast MRI lecture, but that one is going to focus more on implants. Same as other lectures. So let's start out by talking about why would you do a breast MR. They're a pain in the ass to do. Techs have to be trained to position patients correctly. You've got to get a dedicated coil. Patients are nervous and often are complaining and all kinds of different stuff. So why would you bother to do one of these things? So here are the actual indications. Implant evaluation is the big one, and that's the one I'm going to dedicate a full lecture to. There's an old school way to think that if you get an abnormal axillary lymph node and you biopsy said abnormal axillary lymph node, and that yields an adenocarcinoma, and pathologist says it's likely a breast primary, and then you get a mammogram and an ultrasound, you can't find this supposed breast primary. The old school teaching is that the patient gets a mastectomy if you can't find the cancer anywhere else. So nowadays they'll do MR to look for the cancer, and that is an indication that's on the books. Another one is extent of disease, whether or not a lumpectomy can be performed. Assessment for response to therapy. Let me go back to this for a second. So not just assessment for margins for lumpectomy, but specifically in the situation where you have invasive lobular carcinoma. If you remember from prior lectures, that can be bilateral, more and greater frequency than regular IDC. So that's one reason if you had an ILC, you might want to make sure you weren't dealing with one on the other side. Also, seeing how large that tumor actually is would be another reason that you might want to consider MR. Response therapy, do see this done where chemotherapy, and then you can see whether or not there's how much enhancement is left over after that. And supposedly the volume and degree of enhancement does actually correlate with outcomes. Diagnostic dilemmas. So the most common scenario, or the easiest scenario to explain or make for a multiple choice test question would be you have somebody with bloody discharge from a single duct that's spontaneous, so it's suspicious, and you go to do galactography on this person and you are unable or unwilling to cannulate the fucking duct. If you've ever tried to do that, it's a humongous pain in the ass. So MR is indicated in those cases to evaluate for an underlying lesion. And then high-risk screening. So the two big ones are implant evaluation and high-risk screening based on a lifetime risk. The other ones, you could see how they could possibly be made into multiple choice questions. The most common or easiest way to do that would be in the form of a next step style of question. Axillary lymph node, pathologist suggests breast cancer, mammogram negative, ultrasound negative, next step would be MR. ILC, planning, next test, MR. Oncologist wants to evaluate for response to therapy. They're in that paper that I mentioned there. They actually compared MR to mammography, and it was way better for showing treatment response. So MR would be the next step in that situation as well. So let's talk about lifetime risk. Who gets a screening MR? People with a certain lifetime risk, which you'll see quoted between 15 and 25%, depending on the risk model being used. Which risk model will your test writer quote? You'll simply need to read the mind of the person who wrote the test question, and then it will be simple for you to tell which one. Hopefully they won't be huge asshole. Generally, ranges are quoted between 15 and 25, and it's a greater than, so I would hope that the choices would be either under 15 or over 25, but who knows. Another thing is people who've had radiation to their chest, like a child who's had lymphoma that was treated with external beam radiation to the chest. 20 gray is the number to remember for that. Under 20 gray doesn't get it cut, doesn't get the job done. You need 20 gray to qualify for insurance to pay for this. So who decides? The risk models, like I said, depending on which risk model you're using. You see this one here thrown around a lot, and this is the one that's on the lower end of the spectrum, the 15%. So technique. So what if you were asked to set up an MR protocol for breast imaging? What would be the sequences that you would pick, and why? Well, let's talk about why for a second. Breast tumors pathology are often similar in signal characteristics as fat. So you have to suppress fat to be able to see it. There's lots of old talks and books and stuff where they show you the grainy picture of the breast cancer that's occult on non-fat suppressed MR. You have to have good fat suppression. So basically all your sequences are going to be fat suppressed. A T2 is very important because that's going to be your sequence that you use to identify a lot of benign entities. And then you're going to give contrast. So you have to have a T1 pre and a T1 post. And like I said, of course, they're going to be fat saturated. Dynamic imaging is done just like in the prostate to generate curves. Sagittal is typically done, so you usually have axial and sagittal. Don't typically see coronal imaging done. Sagittal is done for like morphology. Subtractions are done, and some places will do MIP imaging. So it looks something like this. And I want to point something out here that's very helpful. See this guy? See this guy? See this guy? See this guy? That's the heart. Most people have one, even the people who write multiple choice test questions for radiology board exams. And notice that it's hard to see on the T2. So that's my trick when they're not labeled to figure out which breast MR sequence is the T2, because they're all fat-satted, right? So be like, fuck, which one of these is the T2? As I'm going to talk about later in the talk, that's like my first step for deciding what stuff is I got to see the T2. So find the sequence that doesn't have a heart, and that will be the one that you start with. Because if you're going to be a breast imager, you have to be heartless. Now, the typical technique here, like I said, most of the time your problems, the big technical issue is an issue with inadequate fat saturation. That's a big problem because you can miss cancers, etc. So you have to use a dedicated breast coil. You can't use the body coil. It doesn't have good enough signal-noise ratio and stuff. So the imaging is way better with a breast coil, and that's what you have to have. So if they're like trying to put together some bogus scenario where they want you to use a body coil, you can't go for that. You got to use a breast coil. Okay, so here's the first situation here, and notice that there's so symmetry is your friend. Look over here. See what this looks like. This is all fat, right? And that's fat satted out, nice and dark. But this piece here is not fat satted out. So you've got shitty fat saturation. So this is a really common cause of problems. So let's pretend that the tech has called you and they ask you what to do. So let's just review how this fat saturation is done. I'll talk more about this in the physics modules, but just a rapid review. So you don't use an inversion sequence anytime you're giving gadolinium, right? Because the inversion time for gadolinium is similar to the inversion time for fat. So if you do a stir, for example, you will null your gadolinium out. It won't work. So you're using like a spectral or whatever type of fat saturation where you're giving a pulse to saturate the signal from the fat. And so for that type of fat saturation sequence, you need a very homogeneous field because you're counting on being able to tell the difference between the resonance between fat and water. And there is a difference between resonance between fat and water, and you have to be able to nail this thing very precisely. Now, this is usually done by a computer, and the way that it does that is that it knows that water is usually the taller peak, so it it does the readout, it finds the tall peak, and then it sats out the other one. Sometimes the computer will screw up and sat the wrong one out. So you can tell the tech to manually select the fat peak. That's one option. Another option is to do something called shimming, which is a technique that makes the field more homogeneous. There's two major types of shimming, one that requires a technician to come in and one that can be done at the scanner depending on the software package you have. But so if given the choice, the first thing I would say is if the breast is completely like there's no fat saturation at all, then I would say that the tech needs to manually select the correct peak. If there is just inhomogeneous fringe stuff, then I would say that you need to do some shimming. Now, other things it can do, like I said, the important thing is that the field needs to be homogeneous. So anything that would make it not homogeneous, like if there was a fold and there was a pocket of air that you could tell like there's a flop of skin there with air in it, and it's inhomogeneous around that, just like you see on brain MR, like around the sinuses and stuff, how it like screws with the homogeneous nature of the image, and the field is inhomogeneous there because you're dealing with a big interface. You could have the tech like reposition the patient to try to flatten that fold out or put a pad there or something. So any kind of like external artifact, if there was metal on the patient, if there was an air pocket, like eliminate that stuff first. If that's not not what's going on, then and it's just like sort of peripheral stuff, then the answer is shimming. If it's the whole breast, there's no fat, it's as if there wasn't fat saturation done at all, then they selected the wrong peak. Okay, so this is something different, and notice that it's the whole way around. So you may say, well, this is the same thing, but notice that it's this whole part and it's this part too. And this is something that you see when large-breasted women in particular are not positioned correctly, where their breasts are too close to the coil. This is called flare or flaring, and it's not true issue with fat suppression. And in other words, it's not that the field is inhomogeneous or that it's selected the wrong peak or anything like that. It's an issue with signal change related to the proximity of the breast coil. So how do you fix this? The answer for fixing this one is not to shim it or not to mess with the peaks or anything like that. You want to pad the breast tissue between the coil elements so that it's not like up against the coil. So that's different. So that would be your main mimic. So make sure that you're getting those straight. And let's look at this one more time. Look how bright that is, and see how that's on the outside of the breast where you can imagine that was touching the magnet. That's different than the other one that we had. A little bit anyway. Okay, so this is our last physics that I'm going to mention for this. And this is a chest MR, right? This is not a breast MR, this is a chest MR. And I just want to point out that we've got a pulsation artifact. You can see this ghosting of the heart here, right? Sometimes you'll see the pulsation of the aorta, like in the abdomen, and it goes in that direction. It's going in that direction because motion artifacts occur in the phase encoding direction. So, and by convention, that is done because that takes longer. You'll choose the shorter, so this is shorter than that, and because time is money on the table, the phase encoding direction is chosen by convention to be the shorter part of the body. This is for body imaging now, abdomen or the chest, and pulsation will head in that direction. That's how you usually see it. Well, breast is different. Breast, they switch it so that the phase encoding direction is the longer way, and the reason that they do that is because they know that there's going to be respiration, right? So you could have respiration or this kind of cardiac pulsation motion, and you don't want that artifact projecting onto the breast. So you're protecting the thing that you care about, and you're sacrificing, there's going to be a little bit longer table time because I'm putting the phase encoding direction in the other way, but you have to do it to maximize imaging. So just to show you, this is a breast, and we've had a little bit of motion artifact here, and you can see there's a shadow of the breast here. Now, motion artifact, it is actually a big deal with breast also, because when you do your subtractions, it can cause significant misregistration and really screw you up where you think things are enhancing that aren't. Okay, so let's move on to parenchymal enhancement. So 2 different cases. This is a case from my book, The Case Companion, and what we've got is someone who was on tamoxifen and then off of it. And you'll notice that the parenchymal uptake is more. There's suddenly more, and this is the so-called rebound or flare effect that people get immediately after they get off of tamoxifen therapy. So background parenchymal enhancement is variable. It depends on the person. It depends on the time of the month. It depends on the contrast agent you use. So if you switch contrast agents, you'll see different background uptake, and you can imagine that when you read these things, you want to be comparing apples to apples. So the best time to scan, this stuff makes great questions, by the way. Which of the following was the optimal time to scan the patient, early in the cycle or later in the cycle? So you want to scan them between day 15 and day 5 and day 15 in the cycle. Later in the cycle and the menstrual or the hormonal cycle, they're going to have more background uptake. So early on, and it's important to scan them the same time they were scanned last time. So it's done early in the cycle. You want them off of HRT for at least 2 to 3 months. You don't want to do it immediately after they've had a procedure or radiation, or that's going to screw up with your enhancement also. So you have to wait. You can't image immediately after a procedure, and you want them off of HRT for a while, and you want to image them with the same contrast agent at the beginning part of the month. By month, I mean their monthly cycle. All right, so let's take a look at this. We'll zoom that up. So this is a nipple, and this is enhancement of the nipple. Now, the oldest trick in the book is to try to get you to say that this is Paget's. This is not Paget's. The nipple normally enhances. But if you, A, have never read a breast MR, or B, never paid attention to the fact that the nipple enhances, that could be tricky. So you will see normal nipple enhancement, and you'll see vessels with contrast on them as well. So next case here, that little guy. He's just a little guy. So this little dot of enhancement is just like in the chest where you have nodules and then you have masses, and there's a size criteria for that. Breast MRI is similar, where you have foci and then you have masses also. So there's a definition which is less than 5 millimeters. So less than 5 millimeters basically means it's too small to accurately characterize. It's just a little dot. You can't run kinetics on this stuff. It's too small. And they typically most people just blow these things off. Now, if you have multiple enhancing foci, like this person does, you don't report them as a specific finding. Instead, you'll lump it in with your comments on the background parenchyma. So when you read a mammogram, how you describe the density of the breast, when you read a breast MR, you describe the background uptake of the breast. This would go in that section. It's not like you don't BR2 this when it's multiple enhancing foci. All right, so what sequence is this? We're going to go through my strategy for how I read these things, with just a little hint. Remember I said if you don't have a heart, that's the T2. Okay, and this bottom one is obviously a post-contrast image. So So let's compare zoomed in here. So we have a finding here and here, and it is T2 bright, and then it's enhancing. It's a round or whatever, but it's T2 bright and it's enhancing. So this is my algorithm. It's pretty simple. Is there a finding? Yes or no? Yes. Is it T2 bright? So if it's T2 bright, then you just BR to it. If it's not T2 bright, then you're going to have to go on and work it up. So T2 bright is used to call stuff benign. Okay, so don't go after enhancement. That's what they want to trick you. Okay, so like renal cell carcinomas enhance, and HCCs enhance, and like cancer in other parts of the body enhances, but in the breast, lots of stuff enhances that's not cancer. Fibroadenomas can enhance, papillomas can enhance, and do. Lymph nodes enhance. So lots of stuff enhances. So if you start calling everything that enhances a tumor, you'll be biopsying everything, which will be just like regular breast imaging. But to have any degree of specificity at all, you use your T2. That's why I made it first. Go to your T2. If you're T2 bright, then I don't really worry about it. Now, for the purpose of multiple choice, there is an exception to the rule, and anytime there's an exception to the rule, it makes it highly testable. So mucinous cancers or colloid cancers are T2 bright. That's the cancer that's T2 bright. They're usually large and circumscribed, and they're uncommon. They make up like 2% of the cancers. But just remember, the only thing you really need to know about mucinous or colloid cancer is that these are bright on T2. Fibroadenoma, I mentioned in the benign talk, and I showed this image, but I just want to rehash it again. Fibroadenoma is a benign entity. Obviously, it's a very common one. It is T2 bright. Books will tell you that it's variable in T2 signal. For the purpose of multiple choice, it will be T2 bright. For the purpose of multiple choice, it will have dark, non-enhancing septations. And I believe that if they show it, they will show it as an enhancing lesion because they're trying to trick you, because that's how I would trick somebody who doesn't know anything about breast MR, was that I would try to get him to say, hey, look, it enhances, it's got to be cancer. And like I said, you want to go T2 first. All right, so next case here, remember, look for the one that doesn't have a heart. That's this guy, okay, and that's your T2. So you look at your T2 first, okay, and you say, we found this is the bad guy here, right? He's enhancing, so then I look back and I say, is it T2 bright? And you can see that it's not really, right? It's T2, it's dark. It's sort of similar to this saturated out fat. So that's bad. So this is something that's going to be bad. So let's go through our algorithm again here real quick, right? So do we have a mass, yes or no? Yes. Obviously, if there's no finding, it's negative. Is it T2 bright? No, it's not T2 bright. So then we gotta go to morphology. So I'm going to say this multiple times here. The margin trumps the kinetics. So don't let them trick you and say, oh, this has benign kinetics, or this has aggressive kinetics, or whatever. I'm making up my mind based on the morphology. I really don't give a shit about the kinetics. I know that it looks fancy, but you make up your mind based on what it looks like. Spiculated masses on mammograms are cancer. Spiculated masses on breast MRI are also cancer. Don't ever let somebody try to talk you out of calling it a BR4 or BR5 if it's a spiculated enhancing mass that's T2 dark on a breast MR, period. So spiculated margin is the single feature that is the most predictive of malignancy. Rim enhancement is also very bad, but it is a less common finding. And here's another very good point. Remember I said that we do dynamic contrast enhancement, so you've got multiple phases. It could be like 5 different sequences of MR that's being acquired, or T1 post-contrast MR that's being acquired at different time intervals. You want to describe the mass margin on the first sequence. not the last, not the middle one, and it does matter. Who does it matter to? It matters to people who write questions. So this is spiculated. Spiculated basically means it has lines coming in and out of it. These are examples of an irregular margin or a circumscribed margin. Probably could have guessed that. So if it has a spiculated morphology, I don't care about the kinetics. So let's talk about kinetics here for a second because it is a testable thing. So it's just like with prostate MR. There are 3 basic curves, and it's best to think about them like the stock market. So your type 1 curve is the best scenario. You buy your stock when it's low, and it just continues to go up and up and up and up and up. The type 2 curve is the intermediate scenario, where you've bought your stock low and it made money, but now it's sort of plateaued out. It's not doing anything, but it's not losing. The type 3 curve is the bad curve. That's the one that goes up fast, and then before you have a chance to sell it, it crashes down rapidly. So rapid washout. And just like the stock market, that's, the type 3 curves are the ones that are supposedly the most aggressive. The type 1 curve would be a curve that you might see with a fibroadenoma. Again, you don't care about the curve because you looked and you saw that it was T2 bright because it's fibroadenoma, and they're going to show you that it has dark internal non-enhancing septations, fibroadenoma. It's going to be a 30-year-old or a 25-year-old fibroadenoma. So you're not going to use the kinetics, but if they would ask you or show you, that would be sort of what you would expect. I don't know if I mentioned, morphology trumps kinetics. So, all right, so again, we've got post-contrast MR here, and this is the finding, and this is described as a non-mass-like enhancement. So with breast MR, you've got foci, you've got masses, and then you have non-mass-like enhancement. And so people say that it's not really a mass, it's more like a cloud or a clump of tissue. These are classified based on their distribution, and the distribution, like the margin for a mass, is what is most helpful for deciding whether or not it's bad or not. Most of the time, this is going to be DCIS. So this was more of a linear distribution. This is more of a segmental or triangular enhancement. Notice that the apex sort of points towards the nipple. Something sort of like that. So there's a whole bunch of different distributions. These are more suspicious because they're more of like a ductal distribution. You can imagine that like being a ductal pathology that was underlying that. And remember from our talk on breast cancer that it's a process that's starting in the duct for IDC anyway. And then this is like more of a diffuse process. So these would be less worrisome. Remember, the distribution is its most predictive feature, okay? And if you were forced to pick one of the 3 bad ones as the worst, it seems like there's a paper that describes segmental as having the highest positive predictive value. So the classic differential is DCIS and ILC, but I think that it will be DCIS if it's asked, just because it's more classic. All right, so that's the end of this talk, and like I mentioned at the beginning of the lecture, our next lecture will be another MR talk focusing on breast implants.